Good afternoon, everybody. Welcome to this Obermann conversation. Before we get started, I just wanted to give a little bit of background on the series and some other events coming up. So my name is Jennifer New, and I am the Associate Director of the Obermann Center for Advanced Studies. The Obermann Center has been sponsoring these talks for the last 3 years with the intention of bringing faculty members and other campus scholars into conversation with people from the community who have shared expertise. The next one in this series will be at the end of March, and it's on local disabilities initiatives, and there will be folks here from the Johnson County Children's Coalition, the UI Center for Disabilities and Development, Seen and Heard, a project of Systems Unlimited, Iowa Public Access TV, and combined efforts. So it's a very large conversation in the scope of things. That event is in conjunction with our symposium, which is April 4th through 6th, which is called Misfitting Disability Broadly Considered. And most of the events for this symposium will be here at the Iowa City Public Library. A few are next door at Merge, and so we welcome you to join us for those. And I'll put these on the back table before we leave. So today's talk, we have 3 guests here today who will be speaking with us. And just to give a brief introduction to each of them, next to me is Steve Stein, who is a research associate at the College of Public Health. He has a master's degree in substance abuse and counseling from the University of Iowa and has worked in the addictions field for the past 22 years. He's also a certified alcohol drug counselor. And Steve was also recently at Prelude in Iowa City, so he has is now on campus, but also has some of that community context as well that he can share. In the middle is Paul Gilbert, and Paul is part of the reason that we got this conversation going because he serves on the Obermann Center's advisory board, and he is in the College of Public Health. Paul conducts research to understand and address alcohol-related disparities. He is particularly interested in the ways that gender, race, ethnicity, and sexual orientation shape drinking patterns, risk of alcohol use disorders, and use of treatment services. His current projects include an NIH-funded study to test an explanatory model of alcohol treatment disparities, a new faculty research award from the College of Public Health to identify and describe the strategies people use to overcome alcohol problems when they don't utilize treatment services, and an evaluation of Iowa's social host liability law that's supported by the Iowa Institute of Public Health Research and Policy. And then on the end is Marv Hain. Marv has a Bachelor of Science degree in Health Promotion and a Master of Social Work from the University of Iowa. He worked at the Iowa City Community Mental Health Center as a homeless outreach coordinator and also at the Cedar Rapids Vet Center. As a certified alcohol and drug counselor, he has worked at the VA Medical Center and the Outpatient Substance Abuse Treatment Program since 2002 and currently works at the Coralville VA Outpatient Clinic. So welcome, all 3 of you.
Thank you.
Yeah, so we've had a chance to talk a little bit between us and kind of came up with a few questions that we want to hit up on and then open to all of you for questions and answers. However, as we go, if something occurs to you, feel free to raise your hand. We do have a microphone, and you will need to wait for the microphone to take your question, as that's how the library's filming system picks that up. So first, I'm asking that each of you, and we're going to start with Paul in the middle here, asks response to some of the lexicon. So what is an addiction and what is recovery? And if you can each provide some brief thoughts on this so that we can start to build on those definitions.
So I think that's a great starting point, and I want to preface my remarks with just a couple of more personal details, I guess. I think it's important to state that I am trained as a researcher. I am not a clinician, so I don't do any counseling or direct work with folks, and that's why we have Steve and Marv here to balance this perspective. I'm also not a person in recovery, but I call myself recovery adjacent, since I have quite a few family members and friends who did have substance use issues, and that's really the impetus for why I got into this field, to try and understand it better. And the third thing I'll say is that as we talk about this, I think it's really important to have person-centered and non-stigmatizing language. So we'll talk about, people with substance use disorders rather than addicts, or rather than people being dirty or clean. There are, folks who are in recovery or in various stages of their recovery or wherever they may be. But all of that said, so getting back to your questions of what is an addiction, from the researcher's point of view, I would define it very narrowly as meeting diagnostic criteria for a substance use disorder. My specialty is alcohol use. That's what I focus on, because I think it's a particularly fascinating substance, that it's legal, widely used, socially endorsed, but we all know that there's potential for abuse and dependence, and has all these sorts of health problems, and we hold these things at the same time and still use it. But in terms of, for the research perspective, we define it very narrowly according to clinical definitions that now, under the current DSM criteria, there's a set of 11 symptoms, and you have to meet 2 or more of those symptoms. And depending on the number of symptoms you meet, we may classify it as mild or moderate or severe disorder. That definition has changed over time, but that's what we've had and we've used since 2013, and is probably the clearest and simplest that we've had in a long time. But for my purposes, it's, do you meet those criteria? How many symptoms do you have? And is that count of symptoms 2 or more? The flip side of that, and what I think is especially fascinating and troubling for us researchers, is what is recovery then? And people have operationalized it in probably 2 primary ways: either abstinence from this substance, whatever is being used. Are you not using it, not drinking, not using whatever it was? And that's a really challenging thing to have as an outcome, to hold it. The other way to operationalize it would be to look at those symptoms again. Do the symptoms decrease? Does your count of symptoms fall below that threshold of 2 or more? And then we say you're recovered. But I got interested in this topic thanks to a colleague of mine several years ago, Leanne Kaskudis, who actually did a study trying to figure out how folks in recovery, whether they use that word or not, define their experiences. And her study was called What is Recovery? And what she found is that there wasn't a simple, easy answer. It was a multidimensional phenomenon, that there were aspects of what you're using or not using. Certainly an abstinence could be part of that. There was also an aspect of service. There was an aspect of sort of being in control of your life, and an aspect of feeling well, or sort of wholeness, so this holistic sense. But it really got me thinking more and more. I had traditionally been looking at who's using services or not, who's getting help or not. And then I started thinking, like, well, we don't even understand this endpoint that we're trying to get to through services or through alternate routes. So it just opened up a whole big question. But from the researcher's perspective, I think we have a very narrow definition of addiction. We really don't know what we're talking about in terms of recovery at all. And that's sort of where I think we're at, so.
Thanks, Paul. Okay. I wanted to start, first of all, I wanted to do my disclaimer. The comments that I expressed today are mine only. I'm not speaking for the government, the VA, Smart Recovery, the Iowa Board of Substance Abuse, or the Iowa Board of Social Work, or any other person or entity. And also I wanted to clarify my certification in alcohol and drug counseling. In 2013, I left the occupation for a couple years and let my certified alcohol and drug counseling certification expire. When I came back in 2015, I decided to get a new one, and when I called the board, she said, for $30 more, you can be an international alcohol and drug counselor. Well, who wouldn't want that opportunity, you know? At least it'll get me dates, maybe, I don't know. But anyway, so there's not a lot of difference, not a big deal, but I just wanted to not misrepresent myself. I'm an IADC and not a CADC. So I wanted to start out, I thought we could expand on this with the American Society of Addiction Medicine's definition of addiction, or what we call ASAM, the criteria by which we also decide what level of treatment a person is indicated for. And they say that it's a chronic disease of brain reward, motivation, memory, and related circuitry. So it's acknowledging the brain chemistry aspect of this. When I talk to folks about addiction, I like to use the example that Craig Nakin uses in his book, The Addictive Personality. And that is that a person, say I'm in 6th grade and 3 of my buddies, their parents are out for the weekend and we got the house to ourselves, and somebody gets a 6-pack of beer, and you know, the 4 of us, we drink the beer, and I'll be the addicted person in this scenario. My friends are like, okay, that was fun, and I'm like, where can we get more? And from that point on, I start to have a relationship with an object, an intimate relationship with an object in Nakin's book. That's his theory. I start to shun the natural sources of comfort in my life, family, friends, community, my sense of spirituality, my sense of self, my confidence, my ability to control my life. Do I like myself? These things start to go out the window, and the substance becomes the main directive in my life. We certainly acknowledge a genetic component, but as was pointed out by Paul, the social component, especially when you're talking about alcohol, is enormous. It makes it one of the most difficult addictions to treat because in some people's subcultures, everybody's doing it. Everybody around them is doing it. People will tell you that a 12-pack a night is moderation. I mean, you can't go shopping anymore, right? I mean, there's grocery stores with bars, and you don't even have to get into the bar part. There's, in the entryway, there's things with craft beer tastings and wine tastings. So it's a very difficult addiction to deal with the triggers for wanting to drink, as opposed to other things. You're not going to see heroin signs up on, you know, billboards and things like that. Let me see if I've hit on everything I wanted. And then there's a point when that use becomes from just trying the substance to impulsive use, which is, now I'm not really concerned about the consequences, and then it turns into compulsive use, in which I'm just using now to eliminate the anxiety from withdrawal. And then if we have the time, I don't want to take up too much time here, but there is a change in brain chemistry that if you ever get a chance to see a video called Pleasure Unwoven by Dr. Kevin McCauley, it explains the disease theory of addiction very well. It makes the case for a disease theory of addiction. How many people out there believe that addiction is a disease? And how many don't? Nobody says no, but a lot of people say yes. I was on the fence, and I don't necessarily feel it's necessary to define whether it is or not. The recovery process is the same, regardless. There is a change in brain chemistry. The movie makes the case that the disease model is an organ, a defect in the organ and symptomology. So the movie makes the case that the brain is the organ. The defect is the brain has been rewired in a not healthy way, and that the symptoms are all of those that addiction involves in all spheres of a person's life. Do I want to do recovery already? Or
Can I just jump in with a quick thought about this?
No, Paul, you can't.
This notion of disease, I think is really important because previous to that, folks were framing, substance use and any dependence as a moral failing, character defect, maybe a choice. It was your person, like you individually were responsible because you were choosing to do this. And maybe there's an element of choice when you first try something, but when we reframe it as a disease model, it's not, you know, you're a bad person, Steve, you're morally deficient because you, whatever. I think that's the advantage to that disease model, even though there's a lot of debate about how much of it is the physiological component and then the social component and cultural factors. And
Yeah, good point. Dr. McCauley actually makes that point in the video that he kind of maybe makes it more optimistic than it is. There's still a large punitive component to being addicted to a chemical in this society. It's getting better, and as I've found through my work, and perhaps Steve has as well, that the Department of Corrections has become more and more willing to allow somebody to get into a treatment program as opposed to jail or prison. And so
And
I think,
I don't know if you want a good historical perspective on how views on alcoholism have changed. There's a book by Bill White called Slaying the Dragon, which is it's a good historical perspective going back into the 19th century, looking at how alcoholism was viewed and treated, as Paul mentioned, from a moral standpoint. So, yeah.
I know, Steve, when we met all together, you talked quite a bit about there being these kind of gradations within, in terms of both addiction and recovery, and especially, maybe you could talk about the recovery part particularly.
Sure. So one of the things that, by the way, my name's Steve Steiny, as Jennifer mentioned, and thanks for organizing this, and Paul, thanks for inviting me many months ago when I had a different job, and then suddenly we're on the same floor
We're
now,
down the hall.
which is unbelievable. And it was nice to meet Marv too and have him part of this discussion. And I want to thank everybody else for showing up on this chilly afternoon. So yeah, I'm a certified addictions counselor. I've worked in the addictions field for over 23 years, and I'm also a person of long-term recovery. So that has had an influence on why I entered the field and why I've made a commitment to try and help others make changes in their life and improve the quality of their life. So, you know, one of the things I have to preface this discussion too is by saying that, you know, people have been using alcohol and other drugs for over 10,000 years. So this is not a new phenomenon. This has been happening. This has been going on. One of the things that I became real aware of as I first entered the field was that people have been using alcohol and drugs cyclically for as I mentioned, thousands of years. What has changed really in the last 50 to 60 years is just our awareness as a community and as a nation and as a state and as a world about the impacts that alcohol and drug use have on individuals' quality of their life. So it's really important for me to remember that, and that I don't think today I was expecting to come in and have the solution or the answer to how to address or treat or solve this problem, because it has been an issue that has continued to puzzle society and those of us trying to help others in this field and patients in this field trying to get better. So I wanted to say that, and then I wanted to say too that my understanding of what a person with a substance use disorder or someone with an addiction involves really focuses around understanding that their substance use is a symptom to what's really happening in their life. So a person's alcohol and drug use is a symptom or an indicator that there's something else that they're struggling with. And this, for me as a clinician, made a lot of sense. And as I worked with and trained other clinicians coming into the field, it was very important for me to keep this in mind at all times. And it ties in with some of the diagnostic criterion we utilize, but it also is really important for me to understand that if I have a patient who's using cannabis every day, and I look at their evaluation and I say, well, you're meeting criterion for a moderate cannabis use disorder, and you're using cannabis every day, tell me what you like about using marijuana. Tell me what it's doing for you. I'm not telling them to quit. I'm not condoning their use, but I'm asking them, well, why? Why they like it. What's it doing for you? And this potentially therapeutically could open up a window for me to have a discussion with them about really those underlying issues that may be driving their alcohol or drug use. We would call these co-occurring or comorbid disorders in the field. But what I would say is that they are really connected to the human condition. And if we think about underlying issues, I would ask, all of you, what are some issues that you think people struggle with in their lives, just in general? Anybody? Depression, so mental health, whatever, what else? What else could influence or be behind underneath someone's substance use? What could be an underlying issue? Yes? Could be stress, yeah. Grief and loss is a big one. And that's often, misinterpreted and misunderstood, but it's a big one. What else? Something yeah, go ahead.
At home life?
Could be past trauma, current trauma, but I think could be chronic pain. We see that a lot. That's a big issue and has been more relevant in the last couple of years with the opioid epidemic that's unfolding before us. So I guess I want to circle back, though, and to kind of build on what Marv and Paul have said, is that if I am looking and working with a person who is struggling with these underlying issues, part of understanding addiction or substance use disorders is realizing that their use is really a way for them to make sense and work through those issues. At least that's their perception. That in the beginning, it solved or filled that void or that niche. Now individuals who, go on to have continued problems, let me just say this. There are millions of people in the United States or worldwide that use alcohol and drugs in moderation. And they manage their lives and they keep it balanced, kind of like Marv was saying, that there's a lot of folks that know when to stop or regulate or how to manage their use. But then there's this population that, for whatever reason, whether it be genetic, whether it be environmental, whether it be psychological, have a difficult time discontinuing their use, and it becomes and begins to affect the quality of their life. So for me, a person's substance use is not, their substance use is not the problem. It's a symptom. It is an indicator that tells me that they are struggling to find meaning and purpose to work through their issues. So as a clinician or as a treatment center, our goal may be to help them explore viable alternatives to addressing those issues that don't involve using alcohol and drug use. We talked about, in 2016, World Health Organization reports that over 3 million people died from excessive alcohol use in 2016. And that's the state of Iowa. And that is not predicted to decrease at any time soon. That continues on. Substance use disorders are progressive. They're progressive in nature, and they ultimately result in significant impact on a person's life. I saw a statistic one time that said 1 out of every 3 people in the hospital were there for some indirect or direct related alcohol or drug use issue. And that, to me, that just was profound. Let me talk about recovery, because recovery is really, when you think about recovery, you think about if a person abstains or discontinues their drinking or their drug use, that they are in recovery. I would argue that they are abstaining, but the recovery really begins once they have decided to start addressing some of these other underlying issues. Recovery is what happens after you stop, after there's a sustained period of abstinence, and you begin to recover both physically, emotionally, spiritually, and psychologically. And this recovery, just as a person's descent into their addiction is often slow and gradual, or for some very quick, the ascent in recovery is also a progressive process. where a person begins to, the quality of their life begins to improve. I can't tell you how many patients that I would see coming into our detox unit that physically looked as though they were a corpse. That their alcohol use or their drug use or a combination thereof had literally put them on death's door. And within a few days, physically, as we put them on a taper, a medical taper to help their body recalibrate, with alcohol use, you can die. Many of you know you can die from withdrawal from alcohol. But to watch them come back to life and physically begin to recover, that part is pretty straightforward. Physical recovery from addiction is, in my opinion, black and white. I can give the person medication and some basic social supports, and physically they will begin to recover. What part of recovery do you suppose takes longer? There's physical addiction or dependence, and then psychological dependence. The psychological dependence is much more complicated, as I'm sure both of these gentlemen can attest to. Psychological recovery, here's what I would do. I would say that, here's how I would explain just a demonstration. So, Dan? Hello. Dan is my new patient. Dan, I'm glad you made it into the session today. I know you're early in recovery, and I have a question for you as we start to work together. What color, Dan, is this card? Green. That's green. I respect your answer, and I understand where you're coming from, but I want to ask you again. What color is this card? Everybody, what color is this? All right, Dan, what color is this card?
It's green.
Okay, so I respect what you're saying, but I need you to accept now. Now, when did you learn that this was the color green? How long ago?
When I was a toddler.
When you were a little kid. I need you to unlearn that. And I need you to accept that this is the color white. So I'm going to ask your peers again. What color is this card, everybody? That's a white card. So Dan, again.
White?
You're cured. Our session's over. How long would it take, how many sessions would it take me to meet with Dan to convince him that this card was a white card? How many sessions, Dan? What do you think? As long as your insurance would pay, I don't know. My point is that undoing what you've learned early on. If I've come to psychological dependence, let's say in the context of addiction, is coming, think about something that you have known and have come to believe that is true. And suddenly, you have someone saying, that's not the case.
So I'm going to jump in.
Yeah, I'm sorry.
No, because that kind of goes toward what we were going to talk about next, which is
Perfect.
around
Yeah,
treatment.
that's good. Thanks for just cutting me off.
No, I hope you have more props.
No,
I don't. So, because we all, as we met, thought that looking at alcoholism was particularly interesting because, as Paul, as you started off saying, what's sort of different about it. And so in the world of alcohol treatment, are each of you seeing right now that you're finding the most promising, the most exciting? So why don't we start with Marv?
Well, first of all, for the pretty much 20 years I've been doing this, primarily I've worked with veterans. So whether there's a difference between working with a veteran population and civilian population, I can't really compare too much. I assume that there's more similarities than differences, but I assume there's also some differences. And I do have some program pamphlets for our program back there, and my business cards, and the Veterans Crisis Hotline on the back table. And I'll be available after the discussion to answer any questions you might have about veteran-specific services. That's what I know. That's why it's interesting that Steve's here, and he's done primarily civilian work, and I'm assuming, and I've done veteran work. So in the VA, we are lucky enough to have lots of different levels of treatment and extended residential treatment. The newest thing that I've seen is eye motion desensitization and reprocessing therapy for substance abuse treatment. It was initially used for trauma, and assuming that addiction often does involve some amount of trauma, it's specified for that in our clinic. We have a social worker that does that. We're lucky enough to have one of my coworkers here today who has a specialty in cognitive behavioral therapy for chronic pain, and as was pointed out when the Drug Enforcement Agency told the pharmaceutical companies to stop producing about 1/3 as much opiates in 2017, we got hit pretty hard in our program with folks coming and saying, primary care doctors saying this person is addicted to this chemical. Well, the actual truth is that oftentimes when a person is taking a chemical like an opiate as prescribed, that they can develop tolerance and dependence on it, but not be necessarily meet the criteria for addiction. So we have to differentiate between that. The medication, acamprosate, not so new, maybe 10 years. Is that maybe?
Campbell?
Yeah.
I don't know how long it's been.
Anyway, that's one of the meds that we use if a person is going the psychiatric route, which oftentimes is necessary. In the VA, some of the programs, we've got a 4-month-long residential program down in Leavenworth, Kansas. We have an intensive outpatient treatment program at our outpatient clinic in Coralville and our Davenport outpatient clinic that's 16 weeks long, 4 months long, 9 hours a week, 2 UAs a week, and 3 breath analysis testings a week. So it's pretty intensive. Other intensive outpatient programs in the area range from anywhere from like 4 weeks to, I don't know how long some of the other ones are, but so we're lucky enough to have this very intense one for our folks. And then I guess as far as new things in addiction treatment, and I'll make this short, I'm not seeing so much directly involved with the substance use aspect as the things around it. So like Steve pointed out, and what we often are reminded of by our folks, is that the alcohol or the other drug is seen as the solution. You know, we help them to see this, that this has become a problem, but it wasn't the initial problem. It was what you used for the initial problem. It's the solution. It's not a good solution. It isn't a sustainable solution. There's a reason that we don't have 6-packs at the VA pharmacy. It works really good for anxiety, but it's not sustainable. And there's this thing called tolerance, and alcohol in and of itself is toxic to the body. And as it's broken down, it's toxic until it isn't, and then it's disposed of. So there's medications. We've got more and more treatments specific to people's post-traumatic stress, depression, personality issues as far as dialectical behavioral therapy, stuff like that. So yeah, that's my comment on what the VA has, at least that's new and available.
Thank you.
It's it. Oh, go ahead, Paul.
I was going to say, sort of from the researcher's perspective, how we tend to define treatment. We have generally 3 bins that we put things into, and there's a whole array of services out there, different ways to approach substance use problems. And the first one that we tend to look at is specialty services. So these would be the inpatient or outpatient treatment, lots of different types. Might be medication-assisted therapy. Oftentimes detox gets put in there, as Steve had mentioned, but technically speaking, that's a medical service, not a treatment service, but we lump it in. Because the idea is that once you go through detoxification, you should be linked to some recovery or a treatment service. But that's sort of the Cadillac bin, the gold bin. We want specialty services. These are designed specifically to address, whatever substance use problem. And then there's this middle range of services, primarily 12-step groups, mutual help groups. Alcoholics Anonymous is the most widely known. It's been around, gosh, going on almost a century very soon. But it's available everywhere in community settings, free of charge, easily accessible, or should be. And there's a lot of other versions of mutual aid groups that are out there as well. Some follow pretty closely that 12-step model, others aren't quite so close. But then there's this third bin of, I guess what we would call non-specialty services. So you may go to clergy, or an employee assistance program, or a crisis center. So these are folks who are not specifically trained to deal with a substance use disorder, and maybe they can't prescribe, say, medication for that, but they're offering some sort of help. There's something that they're giving, and maybe that's what's accessible, or that's what people are using. And then I have recently become interested in what I'm going to call maybe my fourth bin of non-traditional other things that people are doing. And this stems from the realization that treatment utilization for any one of these bins that we look at has traditionally been extremely low. If you look at the whole number of folks who have an active disorder, who are in need of some sort of help, the proportion of folks that are actually getting any sort of help tend to be maybe 10 or 12%. And by thinking about this as a disease or as a medical disorder, this is absolutely unacceptable. We would never tolerate this for any other health condition, that only 10 or 12% of cancer patients get treatment, that only 10 or 12% of asthmatics get an inhaler, whatever it is. But for this, we generally just accept it, or we shrug. It's like, I don't know what else to do. I don't know how to increase this. And we have tried for decades, and we don't seem to be able to budge this much. So this is part of what's driving my research program too, is what else can we do? What do we need to do? Either to expand access to specialty treatment or to go to that fourth bin. What else could people do outside of what we've already been thinking of that would get them to recovery, whatever that is, however we define that and what it means to people. But what is this? And maybe it needs a combination of all of these different things. But that's sort of my researcher summary from, looking at data and not working directly with people. What do I see when I think about treatment and how it's being used?
Could I make one more comment? It was so obvious that I didn't say it when you asked me the question. Probably the most new and significant service that we have through the VA, which is missing in the civilian population in this community, and I think the closest meeting is Ankeny, actually, is something called Smart Recovery. Have folks in the audience heard of this? Yeah, there you go. So I don't know if it's more prominent in the veteran population or not, but many, many veterans, I would say more so than not, are turned off by 12-step programs. Whether that comes from their military experience, I don't know. We can get into more detail on that if you have questions about it. But there was a guy named Jack Trimpe, late 80s, maybe 80s, that developed something called rational recovery, and from that was born Smart Recovery. And Smart Recovery is an alternative for folks that don't care for 12-step philosophy. If you have more questions about what the differences are, we can go into that, but 12-step philosophy being more spiritual, and Smart Recovery being more science-based. So we are lucky enough to have that at the VA. You can, the month of April every year, they oftentimes have a volunteer facilitator free tuition. I think it's what, $75, $90 to take the training. It takes about 3 months, although you don't spend 3 months on your computer. You do it online. But I would encourage someone that's interested in the field to get a civilian Smart Recovery meeting going in this area, because I get calls all the time. Can I come to your Smart Recovery meeting? And because we're a federal facility and we serve veterans, we're not able to provide that service. So, yeah, you asked me what was new, and that's probably the newest, most significant thing, and I forgot to mention it. I got a whole page on it right here in front of me. So, all right, I'm done.
Thank you.
I appreciate that, guys. I think it's interesting because one of the things I do know is that people can and do recover, and I've seen it. And I also know that the substance use disorder, I know addiction, also kills many people. Alcohol takes down more people every year than all the other drugs put together. So we're up against something that I think it's very unfair for me to think that one approach is going to work for everybody. And getting, Paul and I talked about this when we were having discussions prior to this about getting from point A to point B. Recovery or improvement in one's lifestyle or life choices may vary. Someone cutting down or reducing their use may be successful to them. When I used to get calls all the time, what's your success rate? Well, it's difficult to say. We can't track folks that leave our agency. Most of the ones that respond well to treatment, we don't see again. And the ones that continue to struggle continue to return. So it's very easy to get this notion or this concept that treatment doesn't work. We know that it does. There's evidence and plenty of empirical data to support this. What works for who, when, and how varies. That's the X factor. It wasn't so long ago that if I was struggling with my alcohol use, they put me in this place and locked me up. It was called an asylum. And I was deemed morally corrupt and hopeless. And I was left there. Those have all been shuttered and closed. They've been replaced by something called penitentiaries and jails. And those are the new asylums now. And many of our brothers and sisters that are struggling with addiction and mental health are in those institutions. Those are the new treatment centers right now. That's sort of the pessimistic outlook. What I can tell you, though, is that the traditional approach to treatment, and treating someone with addiction sort of went like this. This is a traditional clinician or counselor connecting with their patient for the first time. I'm going to say, Faraji, it's good to see you. I'm going to tell you something right now. You are an addict, and you better admit that right now, and if you don't, you won't finish this program. Admit you're an addict right now in front of all your peers. Well, you're going to be here a while then. That was sort of the traditional approach where I was in his face, I was going to tell him, and I was going to say, this is what's worked because it worked for me, so it's got to work for you. Years ago, not so long ago, 30 years ago, 40 years ago, everyone in the addictions field, almost everyone, was in recovery. So you had everyone sort of marching to the same drumbeat. Everyone was going to get the same treatment because it worked for them. So it's got to work for everyone. What we know as an agency, the agency that I worked for, we were seeing a broad range of people. So we were seeing individuals early on, what we would call a mild substance use disorder, an unspecified substance use disorder, that may not respond to this idea of in your face, you're an addict. And how can I treat someone who hasn't experienced enough negative consequences yet? I may just use psychoeducation, ask them to reflect a little bit about the choices they're making, take a break from drinking or using while I'm working with them, and then they reevaluate at the end of their treatment stay. That might be an entry-level experience. That continuum goes all the way up through the acute, or what we would call severe substance use disorder, where that individual, that patient needs to be in a controlled environment because they have forfeited the ability to stop using. They need to be in a safe, supportive, controlled environment. Now, that being said, this is how we made a shift, and the field made a shift, moving towards evidence-based practice. We know that a combination of different modalities in combination with one another are very effective in helping that person, empowering that person to make some changes. We shifted, the agency that I worked for shifted away from this traditional approach using motivational interviewing and stages of change techniques. Anyone heard of motivational interviewing or motivational enhancement therapy? And stages of change, how about that? It can be used in many different contexts. We were using it, though, in the substance abuse field. And this is how the session would go. Faraji, it's good to see you. I'm glad you're here. I'm wondering, I know you've been drinking for many years, every day. And I'm hoping we can work together. I want to understand what's happening. Tell me what you like about using alcohol.
I like the effect.
You like the effect. What would have to be different for you to make some changes in your life?
I don't know, I'm addicted.
So let's work together and explore what it would be like. And maybe I can learn a little bit more about why you started drinking in the beginning. And you and I can work together on this and see if we can come up with a solution to help improve the quality of your life. Does that sound okay? What an easy patient. But you can see, I'm collaborating with him. Using motivational interviewing, in essence, is using specific language to empower the patient, to help them realize that change is possible and that they can be part of that solution and work with the clinician towards positive change. That's a very quick, overview of what motivational interviewing is. And stages of change is simply saying that each person has a different level of readiness. Why do people change in general? Anybody? Why do people change? Just think broad. Why does somebody make a change? Yeah. Maybe a necessity. Maybe things aren't going well, or the benefits that they were receiving are being outweighed by the consequences. I got to do something different. Well, alcohol or drug use or addiction is in that same vein. When the consequences begin to outweigh the benefits, I'm more ready. If I'm working with a 19-year-old who's had a first OWI, and they may be mandated into treatment. By the way, we know that mandated treatment versus voluntary treatment, the outcomes are about the same. 19-year-old in their first OWI, you think I can talk with them about long-term recovery and what that means to make a lifetime commitment to being abstinent? No way. I'm going to ask them to take a break, consider the changes and choices in front of them, and then they reevaluate. They may be saying, I'm going to get this program done and I'm going to go get my drink on. I'm not ready. And I have to meet them where they're at. I meet them where they're at and I work with them and accept that where they're at is where they're at. It's not where I want them to be. As soon as I take on the role of I'm going to make you do something, well, I'm going to make you stop using, then I've lost you. I am going to say, what would you like to do? I had a patient years ago, 17-year-old Native American kid. First 3 sessions, he looked at the floor and wouldn't engage with me at all. And one day we were talking about whether we should collect a urine sample because his probation officer thought he was still using, his family did. And I said, well, what do you think we should do? And that was the first time he looked up at me and he said, no one has asked me what I think. And it was this moment where I realized that if I can engage the patient and have them involved in the decisions about where we go from here, the more meaning and purpose that those discussions have. So what I know is that people can and do recover. How you get there depends on access to resources. We've talked about barriers to treatment services, and I think that was one of the other questions we were going to address. There are many, many barriers. In 2014, 28 million people in this country needed treatment. About 11% of them were able to access that. And of those 11%, about 650,000 of them didn't want the treatment that they were receiving. So it's interesting that cognitive behavioral approaches, combinations, we know that groups have a very therapeutic component. We did a lot of our services at Prelude in group settings. 12-step approaches, we know there's a lot of anecdotal information to support that it works, but there's also some research that really strongly suggests connecting with others with a common purpose, whether it be AA or RR or Celebrate Recovery, if it's faith-based, if it's, getting from A to B, I don't care how you get there. I just would like to see you have a more rich, fulfilling life.
So I want to see with the time we have left, what questions are out there because we have another question that we are going to address, but I think at this point, let's hear from questions in the audience. And we have a microphone ready as people have a question. Anybody? Thank you for waiting. I appreciate it.
So you mentioned, Marv, that EMDR has been used to treat substance use disorders, and I know, like you said, that started as a trauma treatment. So is the idea that you're treating trauma, which might be contributing to a substance use disorder, or are these two totally separate buckets?
You know, I'm not trained in that specific therapy. I was asking one of the providers that does do that recently, just to prepare for this event, and he suggested that there's kind of two different directions that EMDR can take for substance abuse treatment, and one of them involves a perceived trauma, and possibly the other one doesn't, but more addresses the urges and cravings that one has when they put down a chemical that they've been using a long time. So, yeah, it's something I aspire to train in. I think it's pretty neat the way it works, pretty effective stuff, so thanks for the question.
Anybody else in the back?
Yeah, I think there's something of a problem in Iowa City in trying to locate help for people who are who don't need just kind of counseling therapy, but who are in crisis. And there is nothing available in this town as far as I can see. And this was going back 15 years ago, and going to this day, there's nobody in UIHC, as far as I can see, who has any expertise in treating severe disorders. I've spoken to the head of psychiatry, to the ex-head of psychiatry, and brought this to his attention. There's a new head of psychiatry. I've actually made inquiries recently, and people simply don't get back to you. And this is at the dealing with adolescents, dealing with adults. There's nobody who has any expertise who's prepared to talk to you.
Do you guys have any thoughts on that, or?
Well, I know that there are over 60 psychiatrists in this town. If you don't have insurance, you really can't access them. So that says something. There are some resources available through the crisis center and mobile crisis, but it can be very tricky to navigate and negotiate and access services for someone who's in a psychiatric situation, or a family member who's seeking assistance. So I don't have a solution for you, although I just know that there are resources available. It's just accessing them is very, very complicated to navigate that sometimes. So I definitely empathize with you on that point.
I think, I'm not sure where community mental health went to when it became the Abbey Center for Community Mental Health.
It is.
Maybe,
That's
you
what
know.
it is now. Yeah.
But I think they have a sliding fee scale, don't they?
They do, and they have a walk-in clinic, as does Prelude.
So that'd probably be the go-to for
Yeah.
folks without insurance or low-income
Yeah.
folks.
Other questions? Yes.
Thanks to you all for being at the panel today. I just finished Pollan's book, Changing Your Mind. He talked about, among other things, treating addictions with psilocybin or psychedelics and changing the mind.
Like microdoses? Is that what you're?
Part of it is
Yeah.
part microdoses.
Yeah.
But anyway, I was wondering if any of you had read that or any ideas about that as a new form of treatment.
Oddly enough, it's not new. It's,
Correct, yeah.
one of
It's
the
not
things that
brand
I always have to remember, and I appreciate your question, is that drugs have a way of reinventing themselves and becoming relevant again.
new. Right.
And I know also that this, from my understanding and doing a little bit of reading on this, is that the microdoses are already being utilized in Europe pretty readily. I think there'll be some resistance here in the States. But,
Would you mind just explaining a little bit more what is meant by that for people who might not know?
do you want to take a stab at it, or I can tell you what I know, but let's.
Well, what little bit, I mean, what I know is the microdosing is small doses to basically change some circuitry in the brain. And also, one of the things he talked about in the book a lot was about guided trips. It's not passing out tabs of acid and say, get better. They're guided, structured trips. A set and setting is all very important. There's lots of pre-work that's done.
Yeah, Leary was doing that in the 60s. I don't think it
Exactly,
went anywhere, so.
and that's one of the reasons why it got a really bad rap when Leary came out. Then it went underground. Before that, there was a lot of legitimate research being done.
Yeah.
Bill Wilson had experience with it, so there was lots of legitimate stuff going on. Then it went underground in the 60s, and now there's a resurgence, so.
Yeah. No, I don't know whether it'll get traction, you know, in the field or in the scientific field. I'd hate to imagine the pharmaceutical companies getting a hold of this and running with it, because I don't know.
Actually, the patent on LSD is expired, and psilocybin is a natural occurring substance, so
It's true.
so
Point
it might be
taken.
safe with that.
Yeah. I appreciate your comment. I don't know a lot about it. I don't see that it becoming a mainstream sort of treatment format or milieu, but it certainly could find a niche somewhere in alternative medicine.
Yes, I did bring some samples